Hello, George, and it's another Tuesday morning, and we're getting ready to pack up the bags and go to Orlando for NCE.
Yes. Today we have a repeat wonderful guest, Dr. Jesse Hackel. The topic of discussion for today will be something that affects us all: pediatric workflow issues, or workforce issues, I'm sorry, and the potential resolutions to the problem. Maybe Jesse can tell us how to fix things.
Dr.
No
Hackles,
expectations here, George. No pressure.
I usually resolve all problems, but I'm starting to have problems with this one because I don't know. It's hard.
Dr. Hackle is a frequent guest on the podcast, a friend, a legend among pediatric leaders, and someone's intellect and ability to write I admire. There is nothing nicer than to receive a well thought out written email from Dr. Hackle. I do miss that it's not handwritten and I have to wait because the anticipation, as Kurt Vonnegut used to say, of knowing that letters coming from a friend is a great source of joy. Welcome back.
Thanks, Herb. Thanks, George. It's good to be here.
Yes.
So I'm going to start with a little bit of an explanation because you wear many hats. And today we're just going to focus at your hats at the AAP national level. Prior to this year, you were the chairman of a committee that reviews a lot of what happens in the pediatric office. What was that committee's assignment and job like?
That was the Committee on Practice and Ambulatory Medicine, also known as COPAM. The COPAM is probably one of the most active committees in the academy because, as you say, we were charged with reviewing all sorts of policies and other clinical statements coming out of the academy with a specific eye to assessing them for how they could be implemented in the pediatric practice. Policy is great, and it comes from lots of different places and usually comes from experts in their field. But in the end, no policy is effective or good if it can't be implemented by the pediatrician during an encounter with a patient. And there are a lot of reasons that policies can be difficult to implement, whether it be time or cost or technology needed or things like that may not always be present for the pediatrician. And so our job on COPAM was to make sure that these policies, these good and useful pediatric policies, could actually serve their purpose by being implemented during a patient encounter. After all, that's where it matters, is what we do with the policies when we're taking care of patients. So that's the job of COPAM. And I completed my 4-year term as chair there and 11 years on the committee this past the end of June.
And I'm going to have you hold that thought because I have what you mentioned two things that I think are incredibly important. There's no time, there's no money to implement these policies. But the third thing, which you didn't touch, is there's a lack of knowledge and the way that we engage, I would say mature physicians that are not in training anymore, is not reaching a successful way of engagement and renewal and excitement about these new things that come out because we don't have a good system for that. So now you switch in your chair of an even probably more important committee at the national level, and this is my own bias, but I think that pediatrics as a specialty is in an inflection point. We either pull our boots up and we move forward, or the specialty is going to cease to exist. And so you're now the chair of the workforce committee.
That's correct. As of July 1st, I'm chair of the Committee on Pediatric Workforce. During the last year on COPAM, it became apparent that we were starting to see issues with the pediatric workforce, with the number of new graduates choosing to enter pediatric residencies and the number of graduating residents choosing to go further and enter pediatric care, whether it be general pediatric primary care or subspecialty pediatric care. And at that point, it looked like we were reaching possibly, as you said, an inflection point, but possibly even a more existential crisis for the specialty of pediatrics. We know that the population of children in the country is fairly constant at around 73 million, and it has been so over the past 10 to 15 years. So we're not seeing a growth in population, but what we are seeing is a growth in need for access to pediatric care. And the pediatric establishment, and I don't mean to use that in a negative sense, but the entire field of pediatric medicine is not responding with the increased growth in the number of pediatricians available to help provide that increased access. So even though the number of children may be constant, the demand for pediatric care is rising, and we're having trouble meeting the need for that, meeting the demand for that care in terms of our numbers.
And it's not only the number stable, the makeup of that population is changing. The Anglo population is not reproducing, while the immigrant population is. So the children are looking a lot different than the population in general.
That certainly is true, but while the population may be demographically looking different, all children have the same basic healthcare needs. Some may have greater needs than others, and we may see that in people who are coming to this country from areas where their access to healthcare has been poor. So we may see greater needs in some of those children, and we certainly do find that recent immigrants are having a greater need for pediatric services. But children are children. They still need basic preventive care, which, after all, is a large part of what we do. They still need the screenings for detection of less common illnesses. They still need the mental health care that we're seeing, arguably more now than in the past. So all children, no matter what their origin, no matter their race or ethnicity, all children still need a certain basic level of pediatric care. And one of the things that pleases me over the years that I've been practicing is that we are extending that care to greater and greater numbers of children who previously were underserved.
And then the other thing I see in the clinic is the case sets have changed. And now it's mental illness and metabolic disease. And part of it is because of the clinic that I help, right? It's a high immigrant population, many from Latin America and from Southeast Asia. And so the Central Americans have a greater degree of obesity and type 2 diabetes than the population in general. And the South Asians also are afflicted at a greater number of with type 2 diabetes. And so the complexity and the time that it takes to figure these cases is more significant than it used to be to look at the kid with bronchiolitis, otitis, chickenpox. They were fairly quick visits that everybody got the same symptoms. And I didn't have to think too much about if you're not white, black, and your hemoglobin A1C is a little elevated, the black population normally has a little bit higher hemoglobin A1Cs. That may not be a pre-diabetic yet. All those little things are just more work to be done without the education, because that's not what I learned in residency.
That's certainly true. We've gotten good at managing a lot of pediatric conditions that used to lead to significant morbidity. I think back over the years in practice, and during the last 5 or 10 years, I don't think I admitted a kid with diarrhea and dehydration or a kid with asthma. We got good at managing those things. That used to be a big part. We've also gotten good at preventing infectious diseases with our vaccination program. The infectious diseases like invasive pneumococcal and invasive Haemophilus disease that were a big worry for us many years ago are no longer so prominent or so prevalent because we have effective immunizations. So we have changed the nature of what we handle and the conditions that we manage on a regular basis. And as you point out, many of the conditions that we are finding now that we are left with managing, such as mental health and the newer ones that we see that probably we didn't see much when I started my practice, like type 2 diabetes in kids. These are becoming more prevalent, but they are also far more time consuming than most of what we used to take care of in the past. I think gone are the days where a pediatrician in an 8-hour day could see 30 kids, a mix of well visits and sick visits, and leave the office without feeling like he had gone 10 rounds with Muhammad Ali. I think now if you see 20 to 25 kids in the office, it is a full, exhausting day of work. Again, in part because of the nature of what we do. Remember that the conditions we're treating now But besides being more chronic, besides needing repeat visits and more time to manage, often require consultation with other subspecialists. And simply obtaining those consultations is time consuming as well. Obtaining the education to know how to manage them is time consuming for us as well. I definitely agree with the fact that the changes, partly demographic, partly in disease, have had a definite impact on the regular routine daily practice of pediatrics.
I also think that technology has an effect. All right. Because you have these chronic illnesses. I agree that they take more time, but it takes a whole lot of time for you to write up that big story of type 1 diabetes or mental health or suicide, or you got to write a book. Whereas with an ear infection, LOM, remember those days? Amoxil. Even when you had that, you saw 40 patients a day. And then as paper charts came in and the progress notes had to be longer and longer for billing purposes, it made the visits longer. I find sometimes the technology is what damages the visit and extends the visit a lot. If we could only get the visit shortened by getting rid of the technology, that's a wonderful thing.
I think that's absolutely true. I think the technology has a place, and our documentation is certainly better than it used to be. I still occasionally see an old chart that's like you discussed with the cryptic LOM amoxil. And that's a terrible way to practice medicine. That doesn't serve anybody well. It doesn't serve the child well, and it doesn't serve the pediatrician well, should there be an adverse outcome. So it's important that we document better. What we were talking about originally is the medical part of medical practice. And what you're now getting into is the non-medical part, the paperwork, even though it may not be on paper, of doing medicine and documenting what you do. And that has been laid over on top of the medical part, I think, to the detriment of certainly pediatricians, probably in large part to the detriment of patients as well, who find that they're dealing with a physician who's more distracted by the technology. The good part about technology is that there are solutions either today or coming down the pike that can help do that. The unfortunate part is we implemented the technology before we thought about the unintended consequences, and we're not ready to go when EHRs first came to be. The solutions to the burden that they would pose were probably not recognized, and certainly were not ready to go. And so we were left with having to fight with the technology and only then work to figure out our solutions. And we've all developed our workaround, our tips for charting, our templates. We've all developed ways to work around them. And now we're starting to see the advent of artificial intelligence as potentially a help in dealing with the technology. I think that's in its infancy right now. Infancy is always good for us to talk about in pediatrics, but the use of AI in helping us to manage the technology is something that we may see help to relieve the burden. But again, there's always unintended consequences, and I think we do a terrible job of recognizing what those might be and anticipating them and responding before they become a problem.
What is your experience with AI scribing and things like that?
We're going to get back on topic, George.
Okay.
I'm only going to comment on one thing that Jess said, and it's they knew the unintended consequences because no one has to pay you to go get a smartphone. It's people easily adopted, people want it. And they had to pay physicians, I can't remember if it was like $20 billion overall to put these computer systems in their office. And it was because no one wanted them because they weren't ready. And so they knew they just wanted this. And they put it in front of us and they gave us a carrot and the stick was pretty strong. But anyhow, let's look at the specialty. And when I look at the data, it really is alarming. Burnout is a huge problem. Women are struggling with balancing their workload and their family life. There's really, in some areas of the country, not only Medicaid, but CVS, no payment for the care that we're giving the children. And you see this in recurrent themes. Not only is the payment for an office visit below Medicaid in some markets from the MCOs, but they don't pay for the G2211. They don't pay for screening for depression. They don't pay you for the Vanderbilts. In Virginia, there's a famous program run by the state for people that make too much money to qualify for Medicaid, but not enough money to be able to afford their own insurance for their kids. That one doesn't pay for vaccine administrations. And you can't use VFC on those children because they make too much money to qualify for VFC. And the state of Virginia reimburses their vaccines at less than the cost than you can get the vaccine through a GPO. So it's not just one player, it's all the players. Apparently, pediatricians are suffering from a lot of mental illness. As you both are mentioning, there's a lot of meaningless tasks that we have to complete. Hoop jumping that has never been showed to improve care, physician satisfaction, patient satisfaction. It's just something that someone decides is a good idea and then charges me for participating in it. And the worst one to me is BMI reporting. We don't do anything with a BMI reporting. I'm sure somebody at HHS is doing a study, but it's not changing outcomes. Yeah. And finally, we had a terrible match this year. And so that's basically where we are. Any additions to my list of grievances, Jess?
I think that the things that you mentioned are all present in some degree and to greater or lesser degrees. I think that the overall issue is that sort of contains all of that is applicable to pediatrics in specific, but to medicine in general. And there seems to be overall a devaluation of the services that we provide and the care that we provide. Meaningless tasks take away from the important face-to-face care that we do, and yet people don't seem to realize that impact on the actual care that's given during a patient encounter. Burnout is an issue, but burnout is something that is impacted by so many of those things. When you see one person with burnout, you've seen one person with burnout. They're not the same, and the impacts are not the same. I never found EHRs to be overly burdensome, but I developed techniques to get around that. I never took work home and had to work on the EHR at night because I was able to finish it during my workday. But other people I know spend hours of pajama time working on their EHRs, and that's a cause of burnout. We use the term burnout, but really having to take work home like that is what I would call moral injury. I think it is not appropriate that after working 8 or 10 hours seeing patients, we then have to do that kind of work at home. What other profession, maybe teachers who are responsible for lesson plans, but what other profession do you see having to come home and work so many hours on such a regular basis after every time? So I think that the moral injury that's inflicted on medicine for other reasons, we know that EHRs were not developed to provide patient care. They were developed to make billing easier and more comprehensive, to capture charges. And most pediatricians handled the billing themselves pretty well, whether it was a pegboard system or an in-office computer. And now the EHR has so much more documentation that if you don't document the BMI, the visit's not considered complete by the payer and you don't get paid. If you don't document the BMI on the school form, it's sent back to you by the school nurse. And I agree with you. I think BMI or other indicators of weight for height or obesity are important things for us to know, but they're important for us to know when we're dealing with a patient. Unless that information can be gathered and collected and used to change policy and used to change practice, though I think collecting it centrally, as you say, is a fairly useless task. We've collect all kinds of data. We've yet to see any benefit or any use for a lot of it. I think that's an important point, George.
I think all these screenings, BMI, social determinants of health, whoever invented them, if you were to ask them a question, they'll give you 1,000 reasons why it is a good idea. So they come up with the idea of social determinants of health, and they put it out. Everybody has to do it. They attach some money to it to make you do it, right? Then you have some management level person that says, okay, let's get this. I'll give you an example with our own office, social determinants of health. Is that a good idea to do? What do you think, fellas?
I think you can't throw all the screening tools into the same bucket?
They're pretty much a screening tool. Let's just talk about screening tools. It's a
But
process.
it's different, right? So reporting BMIs has no
Right.
use.
All right. So
Doing
what you have to do.
but George, doing
Uh,
suicide assessment in kids over 11 years, when it's the number one cause of death in the US for children,
Mhm.
has an impact.
Okay.
So
I agree with you.
that's a good
I
one.
agree with you.
Social determinants for me is complicated because it just hurts me. What can I do to change this child's life?
I
But you
agree with you.
cannot look at it that way. You're trying to select people that are higher risk for
Right.
disease burden by knowing these impediments to care.
Correct. Correct.
And so that's what you're trying to do. So that was probably in the
All
middle.
three good ideas.
No,
Yeah, they're
BMIs.
all good ideas. The question is,
Right.
what do you then do with the
So
information?
what I found happens with all of them. All right. Let's start with the BMI since that's Herb's favorite one. The BMI, it's a darn computer. The BMI should be automatically tabulated and reported without my finger clicking anything.
And it is in some place in cases with
It
the
is.
EHR we
And nobody
use,
takes, you know what? Nobody takes the extra initiative to figure out how do I set it up in my EHR so I don't do anything. Even in our brilliant office practicum, it doesn't automatically do it unless there's this little thing that you do.
Well, but think about it, George. Think about other things that we report now. And the big one that we report is immunizations. And in New York, we also report lead to the immunization
Right.
registry.
Mhm.
Those weren't automated at the beginning, and now they are.
Right there.
I give an immunization. When the immunization is entered, it's billed and it's sent to the registry.
Mhm.
When I do a lead test, it comes back from the lab automatically. It populates into the EHR and it gets sent to the registry. So
Process.
technology has
That's not forward
advanced
Right.
since we started. And I wrote the policy statement on immunization registries for the AAP a number of years ago. And even since then, we've seen an improvement in what can be automated and what has been automated. But man, it takes time. We see the need instantly, you
Mhm.
and I, when we're sitting there in front of the patient and we have to click to have it happen. We
Right.
know the need instantly, but in the real world, getting things changed in terms of technology requires the EHR vendor, it requires the agency you're reporting to, it requires the transmission lines, it requires them all to work together. And getting that to happen
That's
is
hard.
not as simple as you and I saying, gee, this should go automatically. It will get there. And I think we're seeing that. You've been a big proponent lately of AI scribing in the office. And that didn't come about till I retired. So I have not had a chance to see it except in a demo. And I think it has the potential for helping us a lot with our documentation. Let's remember, it's not truly intelligence. It's really just data crunching. But nevertheless, it has the potential. But that takes time. And you and I saw the need for that with the first time we opened up an EHR. And yet, how many years did it take for that to happen? Anticipating those unintended consequences might have prepared the vendors to better solve the problem more quickly. And I think that's where we fell down. We focused on EHRs as a billing tool, not as a patient management tool or a record keeping tool. But now we're getting there, and patience grasshopper, as is famously said. We will get there, but not as fast as any of us would like to see.
Remember these people that have the EHRs and the scribe companies, they're a bunch of computer geeks. They don't know what we do in the office. They give you what they think you need. And it, depending on what physicians on the other end telling them what they need, doctors in general are very complicated people. Medicine is super, super complicated. And then they put all these words out to them. And of course, these guys are going to write code to fix your super complicated problem. Even the AI scribes, for example, I've seen perfect, which are simple, easy to use, out of the box, nothing to do. And then I've seen some say, oh my God, why is this so complicated? If I have to do a demo to learn how to use the darn thing, I don't want to use it.
The only thing I push back is because Jess highlighted everything, the opportunities and the failures that we've had, is it irks me that the pediatrician is responsible for the vaccination rates. If you live in certain neighborhoods in the US, either because they're Orthodox Jews or because they're fundamentalist Baptist, they don't vaccinate their kids. And if you serve that community, you can't compete with another community where everybody just says, yes, vaccinate me. And we never have the conversation about patient responsibility. What is your responsibility when you are asked to do something for your health and you decide not to do it? What is the consequence to you? Because you're making that choice. In pediatrics, the child's not making the choice. The parent is making the choice. So that might look like you're not vaccinating for pneumococcal disease. So sorry, but your premiums are going to go up by this much amount to reinsure you against a catastrophic disease.
Yeah, personal responsibility has always been an issue. It goes back to the fact that what, a third or a half of all prescriptions we hand out are never filled. And of
Yeah.
the ones that are filled, they're never taken to completion. You can make that the physician's responsibility if you choose, and malpractice plaintiffs' lawyers like to do that. But in fact, we have to acknowledge as physicians that our control only goes so far. You can tell a patient what they need to do, but the follow through has got to be theirs. And whether it involves charging different premiums or whether it involves other forms of penalization or coercion or a carrot and a stick kind of behavior to the patients, there does need to be some form of personal responsibility. And Americans are independent. They don't like to be told what to do. And you run up against that wall in a lot of places. And this is just another one.
But they're not truly independent. The independent person says, I don't need to be told what to do. I'll deal with the consequences. And they man up. When the consequences come, they man up because they made that choice. The Americans want it both ways. Don't tell me what to do, but when I get in trouble, save me. And I don't want to pay for you saving me. You got to do it because it's what you do. And that dichotomy doesn't allow us to move forward.
I don't think that's Americans, by the way. I think that's human nature. But yeah, it is a problem. It doesn't allow us to move forward.
So I'm going to move to an example, which is the PEDS endo, but you could substitute PEDS ID, PEDS neurology, PEDS behavioral medicine, not behavioral med, but yeah, behavioral medicine, developmental medicine, PEDS psychiatry, general endocrinologist. All those specialties or subspecialties that I mentioned make less money than the general pediatrician. And just as an example, the PEDS endo community only has 1,500 physicians across the country, clustered in major medical centers. And not all of them are clinicians. Some of them are teachers. Some of them are researchers. Some of them are specialized in one gland, like thyroid or bone disease or diabetes. And 75% of that workforce is female. 60% of it is MDs from the US, and at 20% are MDs from not graduated from the US. So it is a highly diverse group of people. But there's simply not enough of them because on the average, they're making around $200,000 a year. And that may be a lot of money to a lot of people, and it is. But in my neighborhood, a bus driver in DC makes $90,000 a year with no special training. And they're not responsible for anybody's life other than if you crash the bus. But they don't have to sit there and look at CMGs and see what your time in range is and try to persuade the parents that a hemoglobin A1C in a type 1 diabetic of 10 or 11 leads to blindness, leads to kidney disease, leads to heart disease. And we need to stop this today. And then we ask them not to see a patient every 20 or 30 minutes, but a patient every 10 to 15 minutes, which makes it really impossible. And it grinds both ways because when I need their expertise, they're booked 4 to 6 months out. So when I have a patient that I no longer feel comfortable managing, and I ask for help from the subspecialist, they're like, yeah, I'd love to help you, but I can't see him for 6 months.
Yeah,
So that hurts them, hurts me, right? That's a moral injury you're talking about because I know what I need to do for this kid. They know they want to help the kid. I have a good relationship with this subspecialist, but there's just no room in their clinic because we're pushing volume and paying very little for it. And we're not pushing quality.
You're bringing this discussion back to the workforce issues, Herb, and which is again where we started. And I think that is reflective, whether it be endocrinology or any of the subspecialties you named, or even general pediatrics. There is not, we're not, it's not so much that we're pushing volume, it's that with the number of kids that need to be seen, we have got to shorten the visits and increase the volume. If we don't do that, then even more kids are going to be underserved. The increased volume, the increased pressure to see more patients more quickly is, I think, a function of the workforce issues that we're seeing. You could argue that the workforce issue is a function of the underpayment as well, and that is certainly true. So they're intertwined in a lot of different ways. But I think that the thing to consider tremendously important is that we are not generating enough pediatricians, whether they be general primary care pediatricians or pediatric subspecialists. We are not generating enough coming out of our training programs in order to meet the needs of the pediatric population in the US. It's just not happening. And if you look at the numbers, you can see why. About 6 years ago, there were about 2,800 new medical school graduates entering pediatric residencies. And this year, again, there were 2,800. There is no growth in the number of people entering pediatric training from medical school. If you look at other fields, you see a slow but steady growth across the board. There were 50,000 people entering the match this past year, up from about 35,000 a number of years ago, and yet not a commensurate growth in the number of people entering pediatrics. When you consider that 2,800 number, that's not all going into general peds or endo or any other subspecialty. That's divided across all of those fields. And so you look at the reasons why that may happening. If we talk about general peds in the first place, before getting into the subspecialties, general pediatricians on average are at the bottom of the pay scale for physicians all the way across the board. And again, $200,000 a year is a lot of money to some people. There's no question. But when you consider the 4 years of college, the 4 years of medical school, and the 3 years of residency, and all the deferred income from those times, it may not be unreasonable. I'm not asking for sympathy, but what I am asking for is a recognition that the services that a pediatrician provides are equally, if not more, valuable than to the services provided by any other field of medicine and should be recognized as such. When you come out of medical school with $250,000 in loans, you're going to go to a field that pays you enough that you can pay your loans off in a reasonable amount of time. So many people still have loans unpaid 20 years after finishing their residency. That's untenable. That is unacceptable when you're going into a field that's dedicated to providing service. So until we raise the level of compensation that a pediatrician can expect to receive during their career, we're going to have problems attracting the best and the brightest to our field. When you get into the subspecialties, Herb, it is absolutely even worse. In what world does it make sense that you will spend an extra 3 years in fellowship training, such as endocrinology or developmental behavioral pediatrics? In what world does it make sense to spend an extra 3 years training for that to make less than a general pediatrician would make during your career? It makes no sense at all. And how we convince people to spend time training for those fields, it's a miracle that people are willing to do it, maybe for the love of the science or the love of the children. But it makes no logical sense. If you spend more money in residency training from being a general surgeon to being a neurosurgeon, you can expect greater lifetime compensation. Why does that not exist in primary care and in pediatrics in general? So the problems are real.
It's also a problem for adult endocrinologists.
Absolutely.
Try to get an appointment with the tsunami of T2D in our country, and not only obesity, but people who are overweight. it is a 6-month wait to see an endocrinologist in Washington, D.C. And to your point, we could have a philosophical argument as to which, if any person in the US should make $1 million running a not-for-profit, or 100 million playing football, or 350,000 being ophthalmologist, or 1.5 million being an orthopedic surgeon. We could have that philosophical conversation. However, if you don't pay, you will not attract the brightest in a system that is somewhat free, and you can choose what career path you want. Obviously, there's some sins attached to it, right? I would say Taylor Swift doesn't need to make billions of dollars in her tour. It's not as important as taking care of sick children. But the market says otherwise. They say it's very important. But if we're going to attract people, it is irresponsible for a young person to go into pediatrics today, knowing that their salary will be $200,000, while they could be any other specialty and they're in $350,000. And so that's over 30 years, $4.5 million of earnings that they're leaving on the table that they could use to feed their families. These are not dumb people. And that's not what George will say. Oh, manual labor is hard. Look, I got no calluses in my hands.
I don't.
But people like you and Jazz and I are smart enough that we could go into another field and not do manual labor. And these young people are incredibly smart. That's why you're seeing them say, I'm not even going to do a residency. I'm going to get my MBA and go work for a consulting firm.
Yeah.
Right? Because they're not dumb. They are not going to be doing my lawn. They're going to go work where they are attracted to a good income that allows their families to have a good life.
But the difference is I've met a lot of physicians who completed residency or completed just medical school, and they ended up doing the technology route or the business route, the administration route, when they don't even have any experience really. Somebody picks them up. So they become what's called an entrepreneur. All right. There's no security. Today you get paid a lot of money. Tomorrow you're not there anymore. Then you got to reinvent yourself, find another job, build it up. You stay there for another year or two, goodbye, move on to somewhere else. You know what? I've seen it all from 96 until today. We rode 2000 crisis. We rode 2008 crisis. We rode the COVID crisis. The doctors just continue to, they're like this.
That's not true, George.
They're stable.
No, it's not stable, George, especially not in pediatrics. The starting salary for a pediatrician in Northern Virginia has been around 160 for the last 15 years.
Right.
Inflation has grown tremendously. You
Right.
cannot live in my neighborhood and make $160,000 a year.
Yeah.
It's just not possible. And when you say it's stable, you're discounting.
The job is stable.
Well, it's not stable because you can't pay your bills when inflation keeps rising and your salary
It
doesn't
should go up. Yes, it should go up.
So,
You should go
so
up.
it's not stable.
You're right there. And you mentioned the market, and the market determines what the sports figures and the concert people and everybody gets paid. And so what is that market saying about pediatrics and the value of pediatric care? But it's not just the market. And I use Medicare, even though pediatricians don't deal with Medicare, but I use Medicare as an example. We have been operating for many years in Medicare under budget neutrality, that when something gets paid more under Medicare, something has to get paid less. There is no other field where, because of population growth, because of technology growth, because of disease or acuity of the work, whatever it may be, there is no other field where the total amount spent is arbitrarily capped so that it cannot go up by this concept of budget neutrality. In fact, it's not stable. We're being forced to do more with the same amount, which translates, because of inflation, to doing more with less. So we talk about a free market system here, but medicine is anything but a free market system. And it's wonderful to think that capitalism will win, but it does not seem to do that in medicine. The laws of economics 101, the supply and demand curve, don't seem to work in medicine the way they work in every other field. And that is the reason that the government has to put these caps on, because it could explode exponentially. But at the same time, it is not conducive to attracting the best workforce and giving them the tools they need to provide the best care for every single patient. And I think that's the situation we find ourselves in, particularly now in pediatrics, but across the entire house of medicine.
And just it's not just the pediatrician, right? If I'm not making enough money, I can't hire a good LPN or a good 2-year RN to help me with my patients. If the dietitian is not making enough money, she can no longer see my referrals. If the speech therapist is not making enough money, she can't see the kids. If the talk therapist is not making enough money, she'll go all cash. And the whole system is crumbling. It's not just we're not paying the pediatrician enough. We're not paying all these expert clinicians that support my job what they need to be paid to be comfortable and be able to see the kids in a timely basis. And that ruins access for all kids, for all
And
kids.
yet, and yet we spend more than any other country per capita on healthcare. And I won't even get into the fact that the results we get for that money are not commensurate with what we spend. We already spend far more per capita than any other country in the world. And we still can't pay people enough to do the work that we need them to do. And I don't understand that disconnect. It makes no sense to me why that's happening. If I dig deeper, I do understand. Unlike most other countries, we have bloated layers of bureaucracy. The number of hospital administrators has continued to increase, even though the number of hospital-based physicians is staying stable. Why does that make any sense? Insurance companies manage to skim 20% of the premium dollar off for their profit, whereas Medicare only requires about 6% for its administrative functions. Some of the answers are readily apparent, but I don't know that we have all of the answers as to why we're spending so much and getting so little for it. It's certainly not going into the pockets of the primary care pediatricians, certainly not enough to attract more to provide the needed services that families are demanding and that families are entitled to. Where is it going? Why is it happening? But that's a big impact on our workforce problems that we have in pediatrics.
This brings up my favorite topic, and I hear people talking about this value-based care, and there's too much spend, and we have to, you know what? The poor guys in internal medicine, family practice, and pediatrics, they don't get paid enough. We know that. But why is there this discrepancy between those guys that do procedures? How can it be that if I put a nursemaid's elbow back in the socket, which takes all of 3 seconds to do, and I get a positive result quickly, it's paid more than my thinking to figure out what that kid has? Why is that, right? And nursemaid's elbow, very simple level. Okay. We're talking about hips and hearts and brains and strokes and all these procedures that come up. That's where the spend is. Unnecessary spend on that, not unnecessary spend because Herb saw a runny nose.
Those are two different issues. One issue is Medicare, which Medicare sole purpose was to get back then what they consider elderly, which I no longer consider elderly, but it's a 65-year-old at the end of life out of the streets dying from cancer, heart disease, strokes. And they nudged the system towards innovation because these were things that were affecting people at their end of life. And prevention was not the key, is how do we better manage a heart attack? And it came great advances. We have MRIs, we can put stents, we can replace valves through the groin, we can do Da Vinci surgery, we can do outpatient surgery, which when I started, everything was admitted the night before for the workup. And the simplest of surgery was a 3-day stay in the hospital. And the recovery was brutal because they opened you up. And the government, they weren't mean. They're like, we need innovation and we pay a lot for innovation. People will figure out how to do it better. And they did. Now they can't put the cat back in the bag. The MRI is no longer innovation. It doesn't need to be paid at $2,000 per film. The other thing, which is a misnomer, and again, I'm going to get myself in trouble. I have asked you not to bring value-based into the conversation because value-based was a cop-out, a cowardly move by the ACA not to talk about what needs to happen. Chronic disease management in the US is poorly managed, and the hospitals make money off of it. And they don't want it managed well because they take 40% of every dollar in the healthcare industry. And if you manage a congestive heart failure well and keep them out of the hospital, they run out of business. And they don't want to run out of business.
Yeah.
So value-based means keep the patient out of the hospital for unnecessary care. That works well in chronic disease if the patient cooperates. That does not work well in preventive medicine. In preventive medicine, we spend more for payouts that may not come for 30 to 50 years. And so preventive medicine is like K through 12 education. You don't ask a school system, what was your profit for this quarter? No one measures it. They're educating children. We need children to be educated to become citizens, to enter the workforce.
Why is there so much talk about it then all the time?
I do think you confuse things a little bit because with K-12 education, we measure graduation rates, we measure achievement on certain standardized testing. So we do look at the value. If you're not getting the value, your school district gets closed down or merged in with another one. So we do measure it that way. But to go back to the concept of value-based care, I think it's a shorthand term for really saying we're spending all this money. Are we getting anything for it? And I think that's a valid question to ask. And I think your point that we don't manage chronic disease well is reflected by the fact that we still see high rates of morbidity and mortality from theoretically preventable diseases, certainly heart disease, coronary artery disease, certainly some malignancy. We do not see a value based on what we have done. But I'll tell you, pediatrics is different. I mentioned before not admitting kids with asthma. What better example of good chronic disease management can you give? With the number of kids that we used to admit with asthma for intravenous aminophylline drips and well before nebulizers, we used to admit those kids all the time. And it's a rare day that a child is so severe that they need to be admitted and treated intravenously for asthma today. And we're still getting better at it. Back in the day, it was the short-acting albuterol and the ICS. Now it's smart therapy, which is trying to coordinate things better and make it more efficient. Pediatrics gets value-based care. What could be better value than a full immunization program? Every dollar spent on immunization saves $10 in long-term healthcare costs. Pediatrics know value. We know that what we do provides value in the long term, and yet it is chronically under-recognized and chronically underfunded. Preventive care is a huge part of what we do, and if you look at the recommendations from the AAP under Bright Futures, you can count the number of visits, you can count the number of tests and screenings and immunizations and everything that a child should have between birth and age 18. You can count them up, you can tabulate them, you can know the cost of each one, and you can come up with a relatively constant and relatively fixed dollar cost for the preventive care needed in the first 18 years of life. We need as a nation to commit to spending that amount for that care for every child, because in the long run, we know the value that produces. And we have not made that commitment. We pay preventive care through insurance the same way we pay sick care. And you're trying to decrease the need for sick care and the decrease for spending on sick care, while at the same time you should be looking to increase what you spend with preventive care because the ROI is so great. So our focus is wrong on what we do. Let preventive care be a given for every child across the board, and then let insurance do what it's supposed to do, which is spread the risk for the occasional or less frequent illness across a population. And we don't do that. And we don't do that as a nation because we're still focused on end-of-life illness care and the heroic surgeries that give somebody an extra 2 months of life and the ICU care at the end of life, because we're still focused on that. And I think that reflects in large part that children don't vote and children don't have a voice. Because if they did, they would demand that 18 years of preventive care because they know the benefits that they'll see for the next 80 years of their lives.
So I'm only going to slightly disagree with you.
Oh, come on.
Because Jess and I have come to where we're at through different paths and different ways of thinking. But you're absolutely right. The conversation to be had is not every child on Medicaid. It's how do we fund preventive care? And I don't know if it's up to for children, but up to the age of 30 for everybody without an insurance company taking 20% of the profit, because it's a known expense. And then the second question that goes with that is, who pays for it? In my mind, only the federal government can pay for that. Because
in the end, you and I pay for it.
no, I understand, but who has the cash today to pay for it? It's the federal government, because it would be equitable across every state, every community. Every child would be given access. Everybody would know what they're going to get paid for seeing that child. And that creates a market. How do we pay for it is the next question, which I would argue that is by a tariff on insurance companies and hospitals. So they get paid, they have to put a certain percentage into the bucket for these things to happen. That's one thing. I push back at the narrative that children don't vote because, and it's going to give you seizures, I'm sorry, but this is a narrative that comes from the American Academy of Pediatrics that children don't have a voice. Have you ever seen the amount of effort that these politicians put into the soccer mom, the suburban mom? That's how they win elections. It has been a total lack of imagination, and we have just allowed people to put us into the triangle of misery where we're victims and we're waiting for a hero to save us.
Yeah.
No, if we want change, we must have great ideas like the one you just articulated. We must come on podcasts. We must talk to people. We must engage mothers who do vote and care about their kids to join, partner with us to change the country.
Yeah.
And they are listened to by every politician in the country. They might not listen to me, but suburban moms, soccer moms, they listen to them. And they worry a lot about them because they are the ones that win elections for them. So it's not that children don't have a vote, it's that we have not figured out the right strategy to go after those moms to help us help their kids. And that's on us. We own that. It's our own fault. Let's get out of that triangle of misery. We're not victims.
Yeah.
We have the power to change, but we need to do the work that takes to change.
Somebody has to lobby. Interesting. I play in a band with a lawyer, and I was having a discussion with him the other day. So this AI ChatGPT stuff, why would I need to have you write me a contract and pay you thousands and thousands of dollars when I could just tell it to make me a contract for an employed physician with the following important topics? He says, aren't you afraid of ChatGPT for the lawyer department? He says, no way, doc. The lawyer lobby would never allow that. There's always some overlord or something that will prevent that from putting us out of business. Not like you doctors.
I'll tell you that
Not like you doctors.
Advocacy is a big part of what we do at the Academy. And to put on my hat there a little bit, last year at the NCE, they came out with a policy statement on Medicaid reform, which was incredibly wide-ranging, incredibly logical, talked about the things that we're talking about, undervaluing the care that we provide children and the ROI of children's care. And it came out and it's essentially gone nowhere, because how do you get uptake from that in Congress when you don't have the ability, the dollars, and the manpower that the lawyers do or the pharmaceutical companies do to send people there? We're working now on a statement on alternative payment methods, and that has to do with value-based care. And I've made the point clearly what I said about preventive care being handled differently from sickness care.
Absolutely.
But advocating for this when you're fighting against lobbies such that are huge, such as the bar, such as pharma, such as even the AARP, we're fighting against our kids' own grandparents in a large respect.
So you're asking for money. Don't we pay dues?
I'm asking for money. Do you know how much our dues are and how much it costs to do a lobbying effort? The AAP has incredible staff in DC, but there are few of them, and they have a limited amount of stuff that they can do. We don't have anywhere near the dollar volume or the vocal volume that these other organizations do. And that's why it's important that each of us adds our voice, because if we don't, we get drowned out, and we get drowned out anyhow. But when there's more of us there, we have a better chance of doing
Correct.
the one-on-one contact that it can take to get stuff done behind the scenes. And again, the staff that works with the AAP and state and government affairs is an incredibly dedicated staff, but there are few of them, and the amount of stuff that's on their plate is massive. And it's massive because this is a massive dollar amount that we're talking about here. But even something as simple as taking a new view to preventive care, how do we actually get that done? Because as you said, Herb, Medicaid is a problem because it's 50 states, all with slightly different rules and regulations. How do we get to change Medicaid to make it more uniform across the country? Because if we could do that, then we could get a universal preventive care services in place. It's there with the EPSDT program, which does specify the basics. And yet insurance companies and Medicaid payers routinely flaunt the EPSDT rules and don't pay for things that they should. So number one, there's no uniformity of requirements. Number two, there's no uniformity of enforcement. And doing that costs money too. And who's going to pay for that?
I think the vocalization is the easy part, but we have to vocalize the important things too, right? Because if I don't exist, there's not going to be anybody to take care of these little children. Let's talk about my favorite topic, CPT code G2211. All right. That was brilliant when it came out from Medicare. I said, this is going to be a savior for everybody. And it worked for a while. Okay. You had some companies that paid for it. Medicare covered it. It was a little add-on for those that don't know what G2211 is, that longitudinal relationship between the physician office and the patient, care coordination, talking to people, getting them in, access, being a doctor, only paid to doctors, not urgent cares in hospitals. It added an extra 20, 30 bucks. I forget how much the number was. And that was great. Then the one big behemoth is said they paid, and they said they're not going to pay anymore. Why would any other commercial carrier follow suit of paying if the big brother doesn't pay for it anymore? Even in the Medicaid managed care companies, some of them covered it, but those that went off of a contract of Medicaid did not cover it. Why is this allowed?
Why is this allowed? It's allowed because of capitalism. The government can't regulate the private insurers and make them pay for anything. I mean, we
shame them into making them pay for it. When it first came out, the AAP came up with a really strong letter, which I thought was brilliant, that I shared with a lot of the carriers to explain what the G2211 is. And it was wonderful. And they put it out in their newsletters and their booklets. It was a good thing. So that they hear us. These companies, understand what the AAP is. They actually listen to us. So we do have a vocalization, but we have to vocalize and talk about it.
And we do, and yet in the end, the companies look at their bottom line and say, whoops, we're paying $20 more a visit than we budgeted. We're going to have to stop doing that. And there is nobody who can tell the insurance companies, this is policy, this is national policy, it's for the good of children, it's for the good of our future voters and our future citizens and our future adults. So you're going to pay for it. There is nothing like CMS, which tells Medicare plans what they're going to pay for, that exists in terms of commercial insurance or Medicaid. And you will never get that changed in our current environment, because free market and capitalism is the way to go. And God forbid we restrict the insurance companies and cut their profits. They'll be on the Hill screaming with their highly paid lawyers, who they can be there a lot more because they're getting paid for it. I'm not getting paid when I go to Capitol Hill to do my advocacy day.
So I have many points of disagreement.
Let's hear it, Herb. Let's hear it.
First of all, the AAP spent somewhere between $0 and $1 million last year lobbying for Medicaid for every child in America as the default option. That was based on and I don't know because I can't find the information, is one of two. That was based on a bill that the senior senator of Pennsylvania proposed to change, basically, as someone at AAP leadership told me, single payer system Medicaid. That is not what we're advocating. It sure sounds like that. And so they put money behind this bill. The way the Hill works is either someone at the AAP, and I don't believe they're this competent, came up with the idea, and then they hired the lobbyist who writes the bill, who finds a senator who will sponsor it. That's one way that DC works. That's how it mostly works. The senators, the congressmen, they don't have the staff, they don't have the bandwidth. The lobbyists write the bills, and then they find someone that likes the idea to sponsor it and put money behind it. Or the other option is the senior senator from Pennsylvania actually does want to put every kid on Medicaid. He doesn't talk about Medicare being the floor. He just says every kid at birth gets Medicaid. Then if they want to opt out, great. If they don't, they continue on Medicaid till they're 26 years of age. End of discussion. Doesn't say we're going to reform it. Doesn't say we're going to put it to the federal level. None of it. Okay. Maybe he came up with it. A staffer in his office did, approach the AAP, and the AAP said, this doesn't sound that bad. It means every child's covered. We're going to put some lobbying money behind it. We're going to write a policy statement that supports this. We're going to do a plenary session at NCE to give it oxygen. And we're going to say it's great and clap our hands. Come on.
Herb, that's not really how the AAP works. The concept of Medicaid for all children is simply a version of ensuring that every child has coverage. As you said, they can opt out. If they have parental insurance through the employers, they can opt out. Right now, half of all kids in the country roughly are covered by Medicaid. The other half have private insurance. There are very few uninsured kids in the country because they have a default to one or the other. So the question is, what can we do to ensure a minimum level of care for all children? And the push has gone, and again, this is not national because Medicaid is not controlled nationally. There are certain basics that are national, but by and large, it's left up to each state to determine how it runs. So what we're seeing in various states, including New York, is a push for initially all children born to have Medicaid for the first year of life, and then for continuous eligibility for up to 6 years. And states are starting to enact that. Why? Because it ensures a basic level of care, and preventive care is the main thing, but it ensures access to care and access to medications for every child. If you change the name from Medicaid to United Healthcare for All, Would it look any better?
That'd be worse. That would be worse.
Well, would it look any better if you decided that Medicare is going to cover 0 to 18 as well as 65 up and up?
I think what makes a difference is your proposal that you put on the table that preventive care needs to be moved out of the insurance market. And it has to be for everybody. There's so many perils, and because I've seen it, you tell a patient, I don't accept Medicaid. They take out a bundle of cash or they take out their Blue Cross Blue Shield insurance card. And Medicaid, because it is not a federally mandated program or financed by the feds, there's a lot of disparity in payment throughout the states.
It is financed by the feds, but the states get to decide
50%.
how they spend the money.
50%. Depends. Some are 90%.
Well, the FMAP is a lot higher in a lot of places. The question is that, yes, there are going to be some people who game the system. And I think the way you avoid the gaming the system, quite frankly, is by not making it optional. By making we have Child Health Plus on top of Medicaid, but making a child health insurance program that applies to every child from birth through 1 year, through 3 years, through 6 years of life, and making that available to every child as a birthright. And I think if you do that, then you take business away from the insurance companies, which I think is a good thing. And then you ensure that kids don't slip through the cracks, because part of being born is access to care. Very simple. And I think that what the Academy is advocating for is not to take current Medicaid and give it to everybody. What the Academy is advocating for is a certain basic level of care, and start with preventive care, because we know that every kid needs it and it will cost a fixed amount for every kid. Start with preventive care and make it available to every child in the United States from birth through some age, and start small and expand it upwards. But that's what the Academy is advocating for. And when you label it as advocating for Medicaid for all, I think you do a disservice both to what they intend and frankly to the work that the Academy does to try and make that a reality. So it's not taking current Medicaid, because I think that horrifies everybody. It's not
That's why it's gotten so much pushback.
It's changing the program and making it into a different animal. The fact that it still has the name Medicaid is probably unfortunate.
Okay, so I agree with you. So come up to the table and be an adult and be forward-looking and present the vision, which you just did in this program. Every child from 0 to 30 should have access to preventive care, because just the vaccination program has extended the life of the American citizen by 30 years. And so there's a huge payout. Now let's be adults and have a conversation of who pays for it? How do we find the money to pay for it? And how do we do it in the most efficient way, as far as not giving United Healthcare, not giving Aetna, not giving Blue Cross Blue Shield 20% to manage an expense that's going to have to be done, and that there's no managing involved.
We spend $13 trillion a year on healthcare. The money is there.
It's there.
It's there. The problem is, Herb, that when you and I see a patient with Medicaid and we get paid whatever we get paid, that money has gone through so many different hands. But where it came from on day one is my pocket, my taxes.
Yes.
So I'm putting the money out there, whether I'm paying taxes or whether I'm paying Blue Cross or United Healthcare, I'm putting the money out there. So the point is that we need to redirect the money. We need to create a system, and I'm getting way out of my field of expertise here, but we need to create a system where part of our taxes is labeled preventive care for children. And by paying more into that, I pay less for the United Healthcare that covers families. Yeah. Same money. Yes. But I have to write a separate check. It hurts a hell of a lot worse. And so you give me back money by reducing my taxes, by reducing my healthcare premiums, and you take the money away by increasing my taxes. That may be a zero sum for me if I think about it. but not for the average taxpayer who says, oh, they're hitting me with this new tax. They're not looking at what they've saved in healthcare premiums. So it's all about perception. It's all about marketing. If we could say that it will cost, I don't know, and this has got no bearing in reality, it'll cost $100 billion to provide preventive care for every child up through the age of 18. Let's find that $100 billion and take it away from the insurance companies, take it away from the current Medicaid program, take it away from useless, low-value care that we give, and put it into something as a block. And let's develop a program nationwide that ensures this for every single child who's in America. And let's start there. But look at the statement from last year's NCE on Medicaid reform, and much of that is contained there. Okay, look at what we're talking about now with our alternative payment models. Much of that is going to be contained in that as well. The problem is we come out with these very good statements, and we still have to get buy-in from people who are influenced a lot more by dollars from pharmaceutical companies, from the hospital associations, from the trial bar, from everywhere else, because pediatricians, we're at the low bottom of the pay scale. We don't have a hell of a lot to contribute to these PACs to influence legislation.
Do you know what, Jesse and Herb? My office used to have 20% Medicaid. Now we're up to 60. Some form of Medicaid. We're subsidized by the commercial payers. We have access to care. We do it all, which is fine. And we see everybody. Okay. What I don't understand with Medicaid for all, the truth of the matter is I no longer see a kid that has no insurance. Right. In the old days, you used to see that and you would feel bad because they had no insurance. Young parents, young children. So now they have some form of Medicaid, which is fine. But Medicaid for all children is a good idea. But there's one more statement that needs to be put after that. And the floor should be at least parity with Medicare.
At least.
No,
not. At least. And it's
no,
not.
AAP makes
no
that.
way. No
Make
way.
that.
You're destroying the specialty with that statement. No way. No way. There is no way. We know that the hospitals and the adult physicians can barely survive on Medicare. And it's just pointed out the physician fee schedule Medicare gets cut down by 3.5% to 4% every year because they don't have the money to finance it. So when we start with that low bar,
okay, 120%.
I won't with 100, 200%.
Right now, Herb, we're talking about 40 to 60% in some states.
Yes.
Let's start with
in Virginia. In Virginia, it's 50%.
And the AAP statement from 2023 makes that point that Medicare parity needs to be the floor.
Yes.
Because that doubles the payments for Medicaid for a lot of us, like yourself in Virginia and like us in New York. That would double Medicaid payments. And that would make a huge difference as a starting point. But what we need to do is get the buy-in that kids are important, kids matter, and that we need to do this for kids because, again, they're the ones who are the future voters. They're the ones who are the future productive members of society. And if we can make things better, the payback will be there, but it won't be at the end of the quarter. It won't be at the end of the year. It'll be 5 and 10 and 20 and 50 years down the road. And getting that buy-in from people who look to the next quarter, if they're a corporation, or the next re-election cycle, if they're in Congress, is really a huge problem. And that's the one that I think we run up against, both personally and even probably the academy, is getting the buy-in to things that are logical, that are actually cost saving, and that will have a long-term benefit. And that's the answer that I don't think we have, is how we get that to happen.
Okay, I have a lot of opinions, and I've been very clear as to how we get there. And it's not through spending money in lobbyists, because you're correct. We pediatricians don't take home $1 million, so we can always throw $100,000 for a huge lobbying event. However, we do have the ear of the mothers that are very important to politicians. So that should be one of our main advocacy or lobbying campaigns, is to bring the mothers into this fight with us. They understand that without teachers, moms, and pediatricians, children can't be raised. They understand it. The second one is the Fortune 500 companies. Because we can't reach the small companies, It's just very difficult logistically. But you talk to any business owner, any CEO today that does business in the US, and they will all tell you the health insurance premiums are killing me. They're killing me. And the insurance companies don't control as much as when one might think. On the Medicaid and the Medicare, the government says this is what we're going to pay per year per child, deal with it. A lot of the work, which is the most profitable work for the major insurance companies, is the self-insured Fortune 500. That money's coming out of the pocket of Sanofi, Merck, Apple, whatever. They pay their own bills. And the insurance company is only managing the network and managing the claims. They take on no risk. If we get to the room of the people that are having to pay those bills, and we make a case, which is a very strong case, of you could see a decreased spend if we move preventive care out of the insurance business. You could have healthier workforces, less days missed of work on your employees because their kids are not sick. I bet you they would listen a lot more than the CEO of Anthem who says, I don't care. 20% of $1 billion is a lot of money. 20% of $2 billion is even more. Spend more. So we're not talking to the right people, and we're using words which trigger us on both sides, right? Medicaid for all makes me nuts because it's a failed program. Okay. So it makes me nuts. We should be talking about what we're talking about. How do we give everybody preventive care? Everybody means everybody. Take that out of the insurance market because there's no need to insure for that. We know what we're going to have to spend. Let's not cheat ourselves by saying, oh, if we could only get to 100%. No, 200%, like every other doctor in the country. That's it. An aspirational goal may not happen before I'm dead, but at least we're walking in the right direction.
That's all well and good. Unfortunately, the soccer moms are not what's the word I'm looking for? They're not a uniform group. You don't go out to the soccer fields and reach all the soccer moms.
No.
It's a different approach. Even the Fortune 500 companies, while they do have organizations, it's a little bit different. How do we get a seat at the table when we're only representing little people? It's tough. It's real tough. And part of what we have to do is make a moral argument that this is the right thing to do. It is the right thing to do for children who don't vote, who don't have a voice, because the parents are, when their kid needs something, the parents are focused on it. But when that need goes away, the parents become focused on something else. We're the only ones who focus continuously on this because we deal with sick kids every day, even though the sick kids change from day to day. And that's the point. That's the role of the academy, is to come up with these proposals. Now, again, these take a lot of time to develop. The alternative payment model one is just getting started. And while I hope to speed that through, these things take a while. We need to develop something, and we are really good at considering the unintended consequences, probably much better than most other policymaking organizations. The academy thinks a lot about what could go wrong with this proposal. And that's one of the reasons that it takes so much time and that there's so much internal review and so much peer review of these things, because we want to make sure we've got all the bases covered before we put something out there and having it blow up in our face. So they do take time. That's the reason I work within the academy. And I've grown there to become a part of a lot of these groups simply by my interest and my participation. And it's incredibly valuable to see how the sausage is made within the academy, never mind within Congress, because it's an educational experience that we want something in our office done. We snap our fingers and it gets done.
Right.
But that's because we're the kings in our office, queens in our office. It doesn't work that way in the real world with most other places. And so it's a question of horse trading. It's a question of being aware of unintended consequences. And it's a question of trying to anticipate what's going to happen 5 and 10 years down the line. And I think the academy and its leadership and the huge number of people like myself who volunteer their time to do this is what gives us the strength. We still have a problem getting the access that we need. And I don't know that there's something we can do as the academy to change that. I think we have to be loud, we have to be persistent, but I think we have to start making a moral argument that there are some things that are just right to do. Never mind that we're wasting a good part of that $13 trillion. And down the road, we could save a part of that, which would come back to my pocket and yours. But we need to make the moral argument that these are our kids, these are our grandkids. And it's not just the soccer moms, it's the grandparents and it's the teachers and it's everybody else. And everybody's busy and they've got other agendas and they've got other priorities. And the academy, fortunately, has this is its focus. And that's where we shine and that's where we have the ability to make our case.
I think we should say G2211 is important to save pediatrics. It will help.
Yep. And the academy did come out and say
yes,
that.
Yes, it was great.
And
data punch second one.
When United Healthcare says, I'm not paying for it.
You got to shame them into paying for it because the rest will not. Why would anybody, if you're Blue Cross or you're Aetna or you're somebody else, if United Healthcare pulls out of it, why in the world would I want to pay for it? But you could shame them into paying for it. Say, hey, United is covering it.
How about
it's the right thing to do?
Argument that this is what's going to ensure care for your kids, and their kids down the road, and that's what's going to keep kids from begging on the street corners.
I agree.
Getting sicker than they need to with preventable diseases. How about the moral argument? I think that's even better. That's the way to shame these big companies, and we've seen it work in small places. So I think that's the approach that we need to take, and that is the approach taken in that 2023 policy statement, and that we hope to take going forward with other policy statements going forward.
I'm very radical, right? I'm not a man of patience like you are, and I apologize for people who think that I'm greedy. But I don't think any pediatrician should be making less than $350,000 a year. That's what it takes to attract the best people into the field. And I'm very proud of this field and this specialty and the people that have come before me and that will come after me. I have no qualms asking that the elected president of the academy make $350 a year, because that's walking the talk. If I say we're important for society, that person that leads us should at least be paid the equal of the median physician in the US to lead us. Maybe more, because if they are the leader of the organization, they should be paid more. They must be more important than me because they've gotten to that level where they can do things. I would like every committee chair at the AAP to be paid a stipend of $1,000 or $2,000 a month to do the work they do, because you do a tremendous amount of work. And it does two things. It creates discipline. When you have to budget for a chair, you might find that there are some committees that are really not that productive, and you remove bureaucracy. But you're also rewarding volunteers, because the $2,000 that you're going to get paid a month doesn't scratch the surface of the hours that you put into doing the work that you're doing.
You know, I don't think that's necessary, Herb. I think,
but it's a recognition of what you're doing.
There is a recognition. I'll tell you, the reward for doing right is its own reward for me. The satisfaction that I get for seeing
you're taking it in a way that is not meant to be taken. We have a payment problem, so we have to value our own so that others will value us. And your time has value. I appreciate all the volunteering you do and the joy it brings you, and I admire you for it. On the other hand, I want that to be given a small token monetary value that says, these people are really important, and we're going to give them something.
That's not something that I would bring back to the academy personally. I don't feel the need to do that. I feel that we attract huge numbers of really incredible volunteers to do this work on a volunteer basis. I don't volunteer for a religious organization, and I don't coach a sports team, and I don't volunteer at the hospital. I volunteer with the academy, and I think that's my community service. And I think if everybody had the mindset, and many of us do, that community service is important, pick and choose where it is, but pick and choose something. And this is what I choose to do, again, for the reward that I get for it by feeling like we're moving the needle a little bit. The academy president is paid, gives up their practice for a period of time, and they're paid in compensation for that. And it's not, I don't think it's far from what you're suggesting. I think that if pediatricians' median salary rose to the national median for all physicians, our workforce issues would disappear overnight. I think that's a great goal. I think that would change a whole lot of minds about pediatrics as a lifetime, as a career, as a commitment. But I think that it's all tied in with the payment and the amount we're spending for everything and stuff. And unfortunately, if we make more, somebody's going to have to make less. And that's a problem because the House of Medicine is not united in that regard. I think we're nibbling around the edges, but I think the most important thing that we can do is make the case for what is the right, what is the moral, what is the necessary thing to do for children's health care. And I think that's what the Academy does well. Unlike some of the other organizations, it took a long time for the Academy to come around to advocating for its members as opposed to just advocating for children. But we're there today, and we're getting stronger in that regard. And I think that's really critically important. We're not going to jeopardize our 501c3 status, but we are certainly going to advocate for our membership and support our membership a lot more than has been done in the past. And so I think that this is the place that we can have the impact. And I'm happy to be doing the work I do, and I'm happy to be doing it on a volunteer basis for all these years because I think it's really important.
And I
Hold on, I'll leave it with this. If people like Herb and I don't get supported and survive out there, we can't take care of the children. And if we can't take care of the children, what will happen? There will be no membership.
That's exactly right. And if we don't get new people to come in and join the academy, both as specialty and particularly as primary care pediatricians, there will be no membership. So this does pose an existential crisis to the academy. There is no question. And that's why we have to support our membership, but we have to bring new people.
I applaud that pivot. It's been a long time coming, but I'm more concerned that children won't have access to care. Doesn't matter what insurance they have, unless they're uber rich and they can pay me $3,000 a year to be their concierge doctor cash up front. They're not going to see a physician of any type, not family practice, not pediatrics. The NPs, they don't want to go into primary care. Only a third of them go into primary care, and they burn out just like the pediatricians do. They leave for something else. So that's more scary than the AAP ceasing to
And their care is not equivalent. As good as it is and as important as it is as a part, it's not equivalent to a pediatrician with 4 years of medical school and 3+ years of residency.
And sometimes, I'm sorry for using this word, but they're abused. There's many practices that use NPs and PAs as the equivalent of a physician, and they skim off the top, and the owner is making tons of money. That's not right. But I do want to ask, payment, I think, is a huge part of our workforce problem. Morale is also a huge part because we don't feel valued, we don't feel heard, and we have lost hope as to how we can get out of this. And that's why I push back so hard against words of children don't vote, we don't matter, we're pixie dust. Words do matter in some ways. We shouldn't use that language because we want to speak to the better half of each human. We're all good and bad, but we all have a good side. And so we want to speak to the good side and provide hope for younger people. in that vein, before we close out the show, because I could talk to you for another 2 hours, but it's the other side of the coin that needs to be addressed, and it gives seizures to people in the organized medicine world, is we need to address the administrative burden. And administrative burden is everything from having to justify changing somebody from albuterol to Symbicort. Why do I need to justify that? That's what the standard of care is. It means clicking on the computer for things that don't have any meaning. It means the governor of the Commonwealth of Virginia asking me to take an additional 2 hours to see on human trafficking. Yeah, it may be important, but I'm not getting paid to do that CME. It's the DA asking me to do 8 hours of mate so that I'm careful when I prescribe narcotics. I can't remember the last time I prescribed a narcotic. So what am I doing that for? I'm not getting compensated for doing that. It's MOC. It's the amount that you have to pay the American Board of Pediatrics to maintain your certification if you're not of a certain age. All of these things, not one, but together, take us away from the exam room, take away from our focus, and people feel exhausted before they take care of the kids.
There's no question the administrative burden is a problem, and some of it is necessary. Those of us who own practices recognize how much we do administration just in our practice alone. Some parts of it are important, and some parts of it are, as you say, burdensome and frankly irrelevant. I think there probably need to be changes, for example, in the controlled substance, that 8-hour CME course that probably ought to only apply to people who have written a prescription for one of those medications in the past 3 years, for example. It could be changed, and we need to advocate for those changes as well. But again, there's a lot of stuff I can think of to advocate for today and tomorrow, and I'm going to pick and choose the ones, number one, that I frankly have the biggest interest in, and number two, and the ones that I think I can get the biggest bang for my time in doing so. But there's a lot of us around, and somebody's interested in that one as well. And so they need to pick that up as a topic and get it advocated for. You talk about what the academy can do, and I've talked about some policy statements, but it would be great to see a resolution that the required controlled substance training system be changed. It would be great to have the AAP advocate for doing that, for example. But that needs to start at the membership level, at the grassroots level. That's one of the ways that the academy learns what's important to its membership and what needs to be advocated for is from hearing from its members. That's a way to begin, is if something bugs you, speak up and get the process going. And I'm not going to discuss that process here. That's something I'm happy to discuss offline with anybody who's interested. But there are ways to have your voice heard. And I think that's important. And with the focus on membership and the focus on improving the lot of membership, I think now is the time to do that.
And then one last thought, and then I'll shut up. We, as specialists, physicians, thoughtful, caring people that we are, we also have to take responsibility. Our specialty is changing, and it's changing a lot faster than I thought it was possible. That's going to demand that we go back and educate ourselves about these new diseases, disease processes, new ways of treating diseases. And the pediatrician of today and tomorrow will have to be a real specialist. You'll have to do two things: preventive care really well, and step up and manage chronic disease, just like we did with asthma. But we're going to have to do it with autism. We're going to have to do it with metabolic syndrome, obesity, type 2 diabetes. We're going to have to send less to the subspecialist so that they have the bandwidth to take care of the. So I'll give you an example. I'm okay managing a type 2 diabetic as long as I can keep him under a hemoglobin A1C of 7 on metformin, and I can get him to lose some weight. But if I can't do that, then that that kid failed what a specialist should do. Now I want a subspecialist to help me figure out, do I have the wrong diagnosis? Should I be more aggressive? Should I start GLP-1? What else can I offer this kid so that he doesn't stroke when he's 30? But we're going to have to step up. We're going to have to ramp up reach-like programs. We're going to have to ramp up echo sessions where we sit down with subspecialists and people have an interest in that disease, and we discuss cases and we build up our confidence to take care of these kids and get paid for taking care of these kids.
And we need to do that without losing sight of the acute care, because some kid is still going to come into the office with meningitis or appendicitis, and we still need to be aware of that as well when we're focusing on the chronic disease. But we have to, I agree with you, the primary care doc has to take on more to relieve the burden from the subspecialists. The question is when they're going to have time to do that. Right. Amidst everything else. And again, it goes back to the workforce. If we don't have more primary care pediatricians, there are just so many patients any of us can see in a day. And if we don't attract more people to pediatrics as a career, which again goes back to the payment levels and the financial rewards, we're not going to be able to serve the patients in whatever field, whether it's the chronic disease type 2 diabetes management, or whether it's the acute care or being there for the preventive care. We're just not going to be able to serve them. So it again goes back to the entire workforce issue. And that's the reason for my focus where it is in the academy at this point.
Thank you.
Thank you for doing all the work that you do and all the work that you have done throughout the years at the academy. You're a true leader amongst us. And
it has been a pleasure. It has been rewarding, and it continues to be so. I hope to continue doing it for a long time.
We'll see you in Orlando, and we'll take a picture.
Absolutely.
We'll do a selfie.
Looking forward to it.
Thank you. It's always a joy to talk to you.
You as well, guys. Good to see you.